Before beginning with the hip examination, be sure to introduce yourself to the patient, including your name and role, confirm the patient's name and date of birth, and briefly explain what the examination will involve using patient-friendly language. Gain consent to proceed with the examination. Wash your hands or sanitize your hands before touching the patient. Ask the patient to adequately expose their legs. Typically, this will involve the patient wearing only their underwear, and provide a blanket to cover the patient when not being examined. Position the patient standing for initial inspection of the lower limbs. Ask the patient if they have any pain before proceeding with the clinical examination. While the patient is standing, do inspection from anterior, lateral, and posterior aspect of the lower limbs. You need to compare both sides of the lower limb, the left and the right. Anteriorly, we need to note if there is any shoulder tilt, lower limb deformity, scars, any skin changes such as sinus, puckering, as well as muscle wasting at the quadriceps. From the lateral aspect, look for hyperlordosis, compensatory stabilization from flexion deformity of the hip, loss of lumbar lordosis, flexed or extended hip or knee, and any muscle wasting over the lateral thigh. Posteriorly, note if there is any truncal listing or scoliosis, shoulder or pelvic tilt, skin changes over the gluteal region, muscle wasting, especially at the thoracolumbar muscles, gluteal muscles, hamstring, as well as the calf muscles, and joint deformity of the ankle and foot. We need to observe for the gait of the patient by instructing the patient to walk from a fixed start point to another end point at a certain distance. Normally, the gait of a normal person consists of heel strike, stance, toe off, and swing. Following are the example of common abnormal gait. The first one is antalgic gait. This is when there is a shortened stance phase, where the pain is in the affected limb. The second one is tendinlimbric gait. This is when there is failure of the affected hip adductor or hip leverage mechanism. On stance phase of the affected limb, opposite pelvis and shoulder will sag down. Trunk will swing toward the affected side to balance the body to prevent from falling. Shoulder will tilt to the contralateral side with trunkal shift to the ipsilateral side. Thirdly, we have a short limb gait. On standing on the affected limb, ipsilateral shoulder will sag down. Similar finding is noted on each step on the affected limb. And lastly is a high stepping gait. This occurs in patient with foot drop. In swing phase, ankle goes into equinus. This is due to the failure of extensors of the foot and ankle. In order to clear the ground, the patient has to lift their foot higher. Patient is unable to have heel strike, thus forefoot will hit the ground first, giving rise to a slapping sound. During inspection, we also need to perform the tendinlimbric test. This is to identify if there is any weaknesses of the hip abductor muscles, which consists of gluteus medius and gluteus minimus. There are two approaches that can be done in this test. The first one is anterior approach and the second one is posterior approach. In anterior approach, instruct the patient to stand on one leg with knee flexion at 30 degrees. Hold both of the patient's palms together with your own palm to prevent patient from falling, and also to elicit the sign. A positive test is when affected side of the body and palm of the patient exerted more force onto your palm than the contralateral side. Next, the posterior approach. Instruct the patient to stand straight with one knee flexed at about 30 degrees, and then observe for the contralateral side of the pelvis. The examiner should squat down behind the patient, holding both of the patient's pelvis. A positive test is when there is a pelvic tilt on the opposite pelvis, while the patient flexes knee of the affected lower limb. Next, proceed to ask the patient to squat. This is to assess intact hip flexion. Next, for the feel or palpation part of this hip examination, ensure that the patient is in supine position. If there is any pillow on the bed, remove the pillow beforehand. This is to allow the patient to lie straight on the bed. Before proceeding with the examination, ask if patient experiences any pain. The examiner should feel and compare the temperature of both lower limbs, and they should feel for tenderness based on the anatomical locations. They should palpate on symphysis pubis, inguinal ligament, the anterior superior iliac spine, the anterior iliac crest, and ask the patient to turn laterally, then palpating for the posterior iliac crest, posterior superior iliac spine, greater trochanter, gluteus medius, as well as the gluteus maximus. Next, to determine if there is any fixed flexion deformity of the hip, we will proceed with the Thomas test. To start, put one hand over the patient's back to look for any increase in lumbar lordosis. Flex the normal hip and knee and observe if there is any active flexion on the affected hip. Ask the patient if they have any pain on bending of the knee. Measure the degree of flexion of the abnormal hip. The reason why the examiner should block the pelvis by bringing the contralateral hip into maximal hip flexion is to eliminate lumbar lordosis that can be used to compensate for the hip flexion contracture of the affected hip. Next is to test the movement of the hip. This action is done only on passive range of movement. This is to test for hip flexion, hip internal and external rotation, as well as the hip abduction and adduction. Firstly, for hip flexion, flex the patient's hip with knee in full flexion and assess the range of flexion. Deduct a fixed flexion from total range. The normal hip flexion is 0 to 140 degrees. Next, for hip internal and external rotation. First, fix 90 degrees flexion of the hip and knee. Hold the foot with one hand and support the knee with another hand. Move the leg laterally for hip internal rotation. The normal range for hip internal rotation is 0 to 30 degrees, and move the leg medially for hip external rotation. The normal range for external rotation is 0 to 60 degrees. Next, for passive hip adduction and abduction, first, square the pelvis by placing the forearm on the anterior superior iliac spine bilaterally. Position the patient's pelvis level perpendicular to the trunk to create a mirror image corresponding to the abnormal side. For a passive hip abduction, abduction, with the patient's legs straight and flat on the bed, use one of your hands to hold the ankle of the hip being assessed and place your other hand over the contralateral iliac crest to stabilize the pelvis. Move the patient's ankle laterally to abduct the hip until the pelvis begins to tilt. Next, for passive hip adduction, with the patient's legs straight and flat on the bed, use one of your hands to hold the angle of the hip being assessed and place your other hand over the contralateral iliac crest to stabilize the pelvis. Move the patient's ankle medially to adduct the hip until the pelvis begins to tilt. The normal hip abduction is 0 to 40 degrees, while the normal hip adduction is 0 to 20 degrees. The Galeazzi's test is done to identify if there is any shortening on the left or right, above or below the knee of tibial shortening from cranial view or femur shortening from caudal view. The steps in this test is first to square the pelvis. The second one is to raise patient's knee into 90-degree flexion both left and right, and the third is to make sure that the ankles are symmetrical, which means the toes should be pointing forward, the medial malleoli should be touching each other, as well as the both knee joints should be touching together. The examiner should look for symmetry in the level of the knees in both cranial view and caudal view for tibial shortening or femur shortening. For the measurement of through limb length, square the pelvis and place both of the lower limbs in symmetrical position. Measure and compare for both sides. Measure from the aces to tip of the medial malleolus for true length inequality. From medial joint line to tip of the medial malleolus for below knee shortening, from aces to medial joint line for above knee shortening. the assessment of apparent limb length, which is only done if there is any suspicion of spinal pathology, you should not square the pelvis. You should measure the length from sternum to the tip of medial malleoli. For the measurement of the Bryan's triangle, which is only done if the shortening is above femur, note the location of the greater trochanter and aces. Draw an imaginary line from first drop of a vertical line from the aces. A second line is from the tip of the greater trochanter, perpendicular to the first line above, and compare both sides for shortening base of triangle to note if there is any shortening above the greater trochanter. If the length is equal on both sides, which means left and right, the shortening is below the greater trochanter. If the length is unequal, affected side should be shorter, shortening is above the greater trochanter. Once a hip examination has been completed, explain to the patient that you have completed your hip examination and thank the patient. To complete your examination, neurovascular examination of both lower limbs should be done. Examination of the joints above and below, which is the lumbar spine as well as the knee joint, should also be done, and further imaging if indicated, for example, plain radiographs, CT scan, or MRI should be done.